Good evening, everybody.
We are live, ma'am.
So, good evening to one and all. A warm welcome to all the distinguished faculty members, respected chairpersons, moderators, panelists, delegates, and participants joining us from across the country for this special World Thyroid Day
We
webinar.
are live, ma'am.
Yeah. So, good evening, one and all. A warm welcome to all the distinguished faculty members, respected chairpersons, moderators, panelists, delegates, and participants joining us from across the country for this special World Thyroid Day webinar.
We are live, ma'am.
So, good evening, one and all. A warm welcome to all the distinguished faculty members. So, I think it is being replayed.
Tech team, can you please check what's the problem?
Yes, ma'am. Yeah, we are live, ma'am. I think it was echoing into someone's mic. We can continue.
So today's webinar definitely promises to be an very academically enriching as well as thought-provoking evening featuring renowned experts across our country who are going to discuss burning thyroid issues ranging from endocrine disruptors to thyroid nodules to radioiodine therapy as well. So we are deeply honored by the presence of stalwarts in the field of endocrinology, endocrine surgery, and nuclear medicine who have graciously agreed to share their expertise with us. So before we begin today's session, let us watch a brief video of the Indian Thyroid Society highlighting our society's mission, the initiatives, and the impact to create awareness on the thyroid health across our nation.
तस्य सर्वमिदं विभाति.
So, to formally welcome everyone to this prestigious academic gathering, I now invite Dr. Pramila Kalra, Madam, who is the President-elect of the Indian Thyroid Society, to deliver the welcome address.
So, good evening, everyone. And I thank all of you for being here today. And all of you agreed to be a part of this World Thyroid Day webinar. And we planned this basically to obviously create awareness about World Thyroid Day. And we have actually got it from many of our seniors, including Dr. R.V. Jayakumar sir, Dr. Sarita Bajaj madam, and now Dr. Kotwal sir, who is the present president. And they are all helping us to carry forward the information and the message which they want to communicate to the public, to the doctors, to the general practitioners. And that's the purpose of this World Thyroid Day webinar. And the other thing, we have also tried to see that all the branches are a part of it, including the endocrinologists, endocrine surgeons, and nuclear medicine specialists, because that is how we want to make this Indian Thyroid Society. And I think we also have an interesting quiz lined up, which our DM students are looking forward to. And this quiz is one of the highlights for all the thyroid clinics which we do, because the DM students look forward to this quiz as well. So at the end of the panel discussions, the talk, and another panel discussion, we have also the quiz lined up. So I welcome all of you, and I sincerely thank all of you for sparing your time to be a part of this webinar. And I give it back to Dr. Gandhi to carry forward the proceedings from here.
Thank you very much, Madam, for those inspiring and warm words of welcome. So it is now my proud privilege to invite Dr. Narendra Kotwal sir, who is the President of the Indian Thyroid Society, for the presidential address. We are deeply honored by your presence, sir. Over to you.
Thank you, Dr. Gyanvi, and namaskar to everyone. On World Thyroid Day, I extend warm greetings to every member of Indian Thyroid Society and to all the dedicated physicians who are taking care of thyroid patients in India. So thyroid disorder is one of the commonest endocrine disorders, yet sometimes it remains under-recognized. And thyroid disorders are posing a public health problem in India, affecting the ages, all ages in fact. And spectrum of thyroid disorders is increasing from iodine deficiency to subclinical hyperthyroidism to frank hyperthyroidism to thyroid nodule, thyroid cancer, and hyperthyroidism. So as a clinician, it is our responsibility to provide ethical care and evidence-based care. Not only that, to diagnose thyroid disorders early and to prevent our diagnosis and our treatment. Plus, we must create awareness in our patients and also in the physician community about the thyroid disorders. And very importantly, to conduct research in Indian contexts. Today is a time to reflect upon the changing landscape of thyroidology. From precision diagnostic tools to molecular testing to advances in thyroid cancer treatment, landscape is changing. Indian Thyroid Society is committed to promote uh, excellence in academics, continuing medical education, practice evidence-based practices, and to increase awareness of thyroid disorders through various programs which society has been conducting for last 1 year. And I'm grateful to all my colleagues for that purpose. Today, let us all come together to provide scientific, compassionate care to our thyroid patients. Thank you and Jai Hind.
Thank you, sir, for your visionary and inspiring address. So now we have the privilege of hearing from one of the pioneers of endothyroidology in India, Dr. R.V. Jaikumar, sir, who is the founder president of the Indian Thyroid Society. Sir's contribution to the development of thyroid sciences in India definitely has inspired generations of endocrinologists. So it's truly an honor to have with us today, sir. So I request you to share your thoughts with the audience, sir.
Dear members, at the outset, let me thank the organizers for inviting me here and giving me a chance to address you, and all the greetings for the World Thyroid Day today. And as you know, about 24, 22, 23 years ago, when I started the society and it was formed, I never thought it would go like this, a big banyan tree like this. And I am very happy that during the last few years, a lot of educational programs are being conducted all over India to enrich the knowledge among the doctors, physicians, and the public about the thyroid problem. Second thing is, I'm very happy that today's topic selection is excellent because we have included a surgically related thyroid topic. We have included radiotherapy related, nuclear medicine related topic, and you have included one of the latest topic on this disruptors, endocrine disruptors. So all the you have got all the top people in the field in the both the endocrinologists, both the endocrine surgeons, and nuclear medicine physicians. And I'm happy that this is going to be a very interesting panel discussion in all the three aspects, and we are going to be benefited by this. And as Dr. Brigadier General Kotwal has already mentioned, thyroidology is advancing rapidly, and we have to keep pace with the advancement of the field. And this society is doing a very good thing, and more work must be done on public education as well as on research, especially related to the other Indian problems of thyroid problems. And I wish all the best for today's symposium. And I wish all the physicians who are interested and who are members of our Indian Thyroid Society all the best on the World Thyroid Day. Thank you very much.
Thank you, sir, for your valuable insights and blessings as well. So now we shall move on to the scientific deliberations for the evening. So the first is the panel discussion that is on endocrine disruptors and thyroid function. So for this highly relevant discussion, we are privileged to have eminent experts from across the country. First, our respected chairpersons for this session are Dr. Narendra Kotwal sir, who is the President of Indian Thyroid Society, and Dr. Arun Menon sir, who is the Secretary of Indian Thyroid Society. We warmly welcome both our esteemed chairpersons. I now request Dr. Arun sir to introduce Dr. Vijay sir, who is the moderator for the discussion.
Am I audible now?
Yes.
Thank you. Thank you, Ganvi. Great to be part of this evening's deliberations. Vijay, as you know, Dr. Vijay Bhaskar Reddy has been a very strong force behind the CME that's been happening over the last couple of years. As you can see, his forte is organizing. He's been organizing secretary for so many conferences. He really takes keen interest and spends a lot of time as a concerned endocrinologist and as a member of the Indian Thyroid Society to do a lot of CMEs. And he really has helped us build this consistently along with Dr. Pramila Kalra and Dr. Ganvi. So over to Vijay for moderating the next session, and we'll be there along with, I'll be there along with Dr. Kotwal as the chair. Thank you.
Thank you, Dr. Arun. I thank Indian Thyroid Society for having given the opportunity to moderate this important session on this hot topic on the occasion of the World Thyroid Day. I thank the chairpersons, Dr. Narendra Kotwal sir, who is a pioneer of environmental endocrinology, and Dr. Arun to chair this session. Can we have the slides of the panelists? So today we are having a very important topic of endocrine disruptors and thyroid function. So we know that we are surrounded by a lot of pollution and a lot of contaminants, and even any food we take, we need to think what is there in this. Any containers, we have to think what is there. So there is a lot of discussion on how this endocrine disruptors affect the thyroid function. And rightly, we are having this important panel discussion today. We have esteemed panelists for today's discussion. And when I was to moderate the session, I told all the top endocrinologists are there in this. So first one, we have Dr. Sarita Bajaj Madam, who is past president of almost all the societies, including the Indian Thyroid Society. And she's got a lot of lifetime awards. And I welcome you, Madam, at Sarita Bajaj Madam.
Thank you.
Next, we have Dr. Shashank Joshi, sir, who is another renowned endocrinologist, and he's from Mumbai. He's been awarded the Padma Shri by the Government of India in 2014. He has been the past president of ITS. Welcome, sir. So next we have Professor Sujay Ghosh from Kolkata, who has been awarded the AAC Outstanding International Clinician Award, and he runs a very enthusiastic thyroid research center in Kolkata. Next speaker, next panelist. And last we have Dr. Sachin Mittal, who is my close friend, and he is awarded the Best Resident Award during endocrinology at Mumbai. And he is founder director of Sweet Diabetes Foundation, and he is quite active in the Indian Thyroid Society. Welcome, Dr. Sachin. I welcome all the panelists. So we can start the panel discussion for today. I'll just share the slides. Okay. The slides are visible?
Yes.
Yes.
Okay. Okay, so as the topic is the endocrine disruptors in thyroid function, so a lot of articles have come, including in the lay public, about this endocrine disruptors and how they affect the various endocrine function. So straight, we'll go to the first question for our panelists, Dr. Sarita Bajaj, Madam. So what are the endocrine disruptors? So how do we explain what type of disruption is happening, and what are the common health risks? We're not talking first about thyroid, overall health risks, Madam.
Thank you. Thank you, Vijay, thank you for the question. And of course, Dr. R.V. Jayakumar, Narendra, Pramila, Ghanvi, Arun, thank you. Thank you for the invitation. So respected chairpersons, so I will take both the questions together. And interestingly, Vijay, the whole story, I don't know whether you think of a quarter of a century as much or not too much, because this whole story started around 1998. And in 2000, they sort of thought of there's a probable connection between these endocrine disruptive chemicals and endocrinology. So if we describe endocrine disrupting chemicals, they are exogenous chemicals or they're mixtures. So they can interfere with any aspect of hormone action. and cause adverse health effects. They can disrupt the endocrine, the metabolic function by not only interacting with the various hormone receptors, but altering the synthesis and degradation. So, you know how many are in use? There are almost 3.5 lakh chemicals and chemical mixtures which are in use, and almost 1 lakh, that's to be more precise, about 85,000 chemicals are their breakdown, or their breakdown products are the ones that are harmful, and these are the ones that are commonly found in the lived environment.
Thank you, madam. Thank you for
Now,
introducing.
the common health risks, the second part of the question was, so they can, from adverse birth outcome, neurobehavioral, neurodevelopmental, reproductive, obesity, cardiometabolic, musculoskeletal, immune system, and various cancers as well. As far as the thyroid is concerned, they can cause alterations in the thyroid hormone levels, hypothyroidism, goiter, thyroid nodules, and thyroid cancer as well. Whether it is the perchlorate or the PCBs, that are the polychlorinated biphenyls, triclosan, polybrominated diphenyl ethers, and bisphosphonyl A. So they have structures which are similar to the thyroid hormones. Therefore, they disrupt thyroid hormone synthesis, transportation, metabolism, or action. So this is just in a nutshell as to what the definition is and what are the actions on the thyroid of these EDCs. Thank you, Vijay.
Thank you, madam. Thank you for introducing the concept of endocrine disruption and how they affect the various parts of hormone production, hormone synthesis, and feedback, and especially the effects on the thyroid. So, as madam told, we have lakhs of chemicals now. It becomes difficult to identify which chemical is going to act where. So, we seem to be surrounded by endocrine disruptors all around. I request Professor Shashank Joshi, sir. So, what are the common sources of endocrine disruptors in India, and which are the common sources, like food or water or air pollution? So, what will be the common sources, sir?
So thank you, Dr. Vijay Bhaskar Reddy, and I must congratulate our current president, Dr. Kotwal, and Dr. Arun Menon, and all of you all for being. And I think I wish everybody a very happy World Thyroid Day. My respects to Professor R.V. Jayakumar sir, Madam Sarita Didi, and everybody around here. And Vijay, thank you for this. So endocrine disruptors, as Didi said, are very important, but they have a lot of sources. The commonest source is every day when we get up in the morning is toothbrush. Toothbrush has fluoride and toothpaste, and that fluoride is a halogen which interferes with iodine metabolism. So that's the first source of endocrine disruptor. Second is the water which we drink from plastic bottles. They have phthalates and they are endocrine disruptors. Then from the air, we have a lot of endocrine disruptors which are there. The pesticides, the agriculture, the food which we eat, they are laden with a lot of endocrine disrupting chemicals. And some of them have a direct impact on the autogeny of goiter. In fact, I gave a talk as a plenary talk as the Garib lecture at the ACE meeting, and I spoke on this entire subject. So I think, our air, water, or the food which you consume has a lot of hormonal disrupting chemicals which also impact thyroid biology. But what is particularly distressful for the thyroid is a toothpaste which has fluoride, which is competing with iodine as a halogen. The phthalates which are there in the plastics, which are also competing with iodine as a halogen and are triggering autoimmunity. And then various foods which are all ultra processed foods, and all the ultra processed foods and their preservation and the preservatives are predominantly responsible for the increase in the autoimmunity. And this is a very well established entity now. But whether it is the cause or effect, or whether it is just a trigger, is not something which we know. But also the other thing which endocrine disruptors do is they cause epigenomic changes. And these epigenomic changes means even if you are genetically not predisposed, you then do that. We are in the iodinization phase. And because we are at the peak of iodinization phase, we are seeing a shift in cancer biology. And even in the cancer oncogenesis, we are seeing a shift from the traditional follicular neoplasms, anaplastic neoplasms to a papillary neoplasms because of iodinization. And in the but if there is continuous exposure to exposomes of endocrine disruptions, we will again see resurgence of anaplastic and follicular neoplasms. So I think it is important that we are mindful of the air we breathe, we are mindful of the food we eat, we should be mindful of the toothpaste which we use, and we should be mindful of the water we drink, because these are the common sources. Of course, this is an endless topic and a subject matter for a separate lecture, but it's a very good, exciting area for research as well. And I think we should be very mindful. Particularly, we can see now one common endocrine disruptor for thyroid is the dry heat and the wet heat. And right now, we know that across India, the ambient temperature is between 35 to 45 degrees centigrade. And half of India has wet heat, half of India has dry heat. And that actually propels halogenesis and goitrogenesis, and it interrupts and disrupts the iodine metabolism as well as tyrosine metabolism. So those impacts are also very well known. As I said, this is a very exciting area of environmental disruption, and there is no clear-cut guidance on the same. But I think we should be mindful. We cannot give any classical recommendations because. But one thing is very clear-cut: avoid ultra-processed foods, drink boiled water, ensure that when you are using toothpaste, we can use non-fluoridated toothpaste, and many other simple recommendations can be done, but there is no direct cause effect relationship. So as Indian Thyroid Society, we cannot recommend any major changes, but we should be mindful of food and water, and we should be mindful and also remember that many of that triggers obesogenesis. So many of them endocrine disruptors are also obesogens, and obesogens trigger thyroid autoimmunity as well as oncogenesis. So we have to be mindful and careful. But currently, as I said, the research is scant for a cause effect relationship to make any generalized recommendation. Thank you so much.
Thank you, sir. I think sir has clearly highlighted that right from the time we get up till what we drink, what we eat. So we need to be careful, even for ourselves and for our family. Thank you, sir. So there are so many thyroid disruptors. Professor Sujay, sir, you are there. So many lakhs of thyroid disruptors are there. So which chemicals have currently the strongest effect on thyroid function, sir? You would like to highlight 4 or 5 chemicals?
Right. First of all, thank you very much to the Indian Thyroid Society and all of the respected seniors and colleagues who've given me this opportunity to interact with all of you. And like my previous panelists have already highlighted the major EDCs, which are probably working on a lot of organs, not just the thyroid. But if you try and minimize or narrow down to the thyroid, again, this is much area of research is needed here, but the common EDCs that we think have an effect on the thyroid gland include perchlorates, the per and polyfluoroalkyl substances, the polychlorinated biphenyls, and the polyelectrolyte and the flame retardants, the bisphenols, and some of the notable disruptors are the phthalates and the pesticides, even DDTs and organochlorines. Now, each of these have various mechanisms of actions. For example, the perchlorate directly blocks the sodium iodide transportase channels. The perfluoro and polyfluoroalkyl substances probably displace the thyroid hormone from the binding proteins, and the PBCs accelerate the clearance of the thyroid hormones from the body. The bisphenols act at the level of the thyroid receptor and cause a form of thyroid hormone resistance. So these are all mostly animal model studies that I'm talking about, because like Dr. Shashank said, that most are association studies rather than direct causation or causality studies with exact mechanisms. But these 5 groups is what I would say are the most important and the most important postulated mechanism through which these particular chemical substances work.
Thank you, sir. What will be the common sources of this perchlorates and thiocyanates?
So it would be food, whatever you're consuming, whether it's the water or whether it's the vegetables that we are, consuming. It'll be in both of them. That would be the commonest source.
Thank you, sir. So there are so many chemicals affecting the thyroid function and causing thyroid disruption. Dr. Sachin Mittal, I think already the previous speakers also highlighted some of the mechanisms. So would you like to highlight the mechanisms of thyroid disruption?
Sure, thank you. Good evening, everyone. At the outset, many thanks to Indian Thyroid Society and all the esteemed faculty and senior endocrinologists for this particular seminar and this academic initiative. As already highlighted by previous speakers, the endocrine disruptors are almost everywhere. You look at water, you look at air, you look at food, they are omnipresent, right? So how do they interact? How do they actually act specifically on the thyroid? You can look at the action at the multiple levels. So right at the action at the central level, so at the HPT axis. So there is some studies which say that probably they interfere with the altered signaling at the level of TRH, TSH, or even mimicking or blocking thyroid hormone feedback. So as Dr. Sujay Ghosh earlier was highlighting, and then you have the action which is by perchlorates and thiacyanates, where you have inhibition of iodine uptake, and we know that iodine is the basic substrate through which you have the formation of the thyroid hormone, by competitively kind of blocking the sodium iodide symporter. And then you have problems in terms of in terms of difficulty in terms of thyroid hormone transfer, either through the action at the level of binding protein or even thyroid hormone synthesis by acting at thyroperoxidase, which is an integral part of thyroid hormone synthesis process. So all of these things, they actually interfere, and they lead to an abnormal thyroid function. And coupled with that, then you have the aspect of the conversion from the storage form of thyroid hormone to the active form of thyroid hormone by deiodinases. That actually also gets blocked. So in a way, you get a less of a actual bioactive thyroid hormone or actual free thyroid hormone in the concentration. And on the other hand, you have a reverse T3, which is more there. So as a result of this, at all the levels, the disruptors are happening, the disruptors are acting, and as a result of which we have an abnormalities in thyroid metabolism which happen over a period of time. And as already highlighted, there are a number of key components, whether you talk of bisphonates, whether you talk of bisphenols, whether you talk of phthalates, whether you talk of thiocyanates or perchlorates, which actually act at different levels. The most common culprit actually are the ones which is, like say, plastic bottle, drinking water in a plastic bottle, or especially hot food, which is, kind of, eaten in a plastic container or stored in a plastic container. Like many days, now people are ordering food from outside, and invariably, most of the times that's coming in a plastic container and stays there for sometimes hours together, and that's what actually generates it more and more, which is somewhat avoidable source. And also the water, kind of boiling it and helping it. Many of the things like pesticides in agriculture, I mean, honestly, some of them are beyond control. I mean, it's very difficult for us to, kind of, select which vegetables do not have pesticides and which vegetables do not have pesticides. But yes, at least the use of plastic bottles we can minimize.
Thank you, Dr. Sachin. I think he has highlighted that almost all the process of thyroid pathogenesis, thyroid hormone synthesis and function get affected. And next we move on to, I think already Professor Shashank Joshi has highlighted this, that so many thyroid disruptors are there and a lot of association is there. But can we say the association as causation, or how robust is the clinical evidence to link this thyroid disruption process? And why is it so difficult to prove causation? Over to Sarita Bajaj.
Thank you. Thank you, Vijay, for that question. Now, interestingly enough, in studies in animal models, there is an overall agreement regarding the harmful effects of the PFA, that is the per and polyfluorinated alkyl substances. So both the long and short chain and their alternatives. And these are widespread environmental pollutants, and their role is thyroid function. But on the other hand, their role as thyroid function disruptors is still controversial. Okay, so in vitro studies, there seems to be some overall agreement regarding the harmful effects. So we have effect on mice, demonstrating affecting development of the fetus, zebrafish, highlighting an interference on the embryogenesis. So we can overall say that in vitro animal models, the data is consistent and definitive. However, in vivo data in humans is very controversial. regarding the potential thyroid disrupting effects with great discrepancy among the different studies. So if we look at the onset of hypothyroidism in PFA's exposed communities or in the general population, but again, there is some inconsistency there. So even if it is probable, it can cause detrimental effects on fetal growth. Again, doubtful if this effect is mediated by alterations in thyroid hormone homeostasis. So at the end of the day, we need far more longitudinal, long-term exposed population studies, which are specifically designed for evaluating the biological consequences of chronic exposure to the PFAs. So there is some epidemiological evidence between EDC, thyroid cancer, right? Phthalates, heavy metals, there was a positive association, no association with BPA, and most studies did not show publication bias. So this is in brief as to where we are right now. So regarding the studies, the cause or the association between the EDCs and thyroid disorders.
Thank you, madam. I think madam has clearly highlighted that association is not equal to causation. So I think there are some red alerts. I think we need more studies. We cannot equate animal studies to human studies. So we need more evidence for recommending further about EDCs. So regarding exposure, sometimes we have acute exposure. We see some people drinking water and everyone in that community are getting affected. Another is happening low dose very chronically when very difficult to link. So Professor Shashank Joshi sir, would you like to highlight about low dose chronic exposure versus high dose acute exposure? Any differences with regard to endocrine disruptors?
So, Vijay, before I talk on that,
Yes.
let me be very clear on two areas. So one is
Yes.
that, exposure, very high dose acute exposure is always worse than chronic low dose exposure. But there are two vulnerable populations at risk within the thyroid community. So, people who are planning pregnancy or are pregnant, infants, CKD patients, and people who have autoimmunity which is present, the exposure matters. So it's important to identify at risk population. That's something which is very clear. And we have to see that, you know, what is the sensing hormone or the sensing area, for iodine is the NIS in the thyroid tissue in the iodine uptake. And it is basically the symporter is blocked by the perchlorate, which is the bisphenols and the perchlorates. The we all know the TPOs and the is inhibited by SOE and BPA. So it's like the processing is upset. The PCBs displace the transportation. The binding is affected, or the TR betas are activated by BPAs. So there is a lot of and the triclosans and the PCBs, they will fundamentally impact the metabolism of clearance. But there are some red flags which we have to identify, which are important when we look at a low dose or high dose. High dose exposure can cause challenges, so can low dose exposures, but unexplained TSH rise with a low normal free T4 in a young adult, a goiter without antibody positivity in a non-endemic area, worsening of hypo despite of a thyroxine compliance, a check for SOA, calcium, ion timing, and EDCs. And in pregnancy, if there is subclinical hypo with EDC exposure, the risk of offspring with IQ loss. And CKD uremia alters the T4 to T3 convergence. So EDC can be a second hit. So clearly, we need to recognize that both acute and chronic disruptions can matter, and we need to be a little more mindful. As I said, the data on this is very scant. Clinical recommendations are not something for prime time. It is more of a discussion in the space of experimental medicine, and therefore, the exposomes, we need to do that. But all I wanted to highlight is when there is a CKD patient with thyroid, we should be mindful of EDCs because they matter in that situation. If it's a pregnant environment or a small child or infant, we should be mindful of that. These are the two prime situations where I really feel clinically the exposure will matter. And I think in all other circumstances, the cause-effect relationship is still under investigation. So we don't have any verdict on the same. That's all I would like to say.
Thank you, sir. Thank you for highlighting the exposure of the endocrine disrupting chemicals. So I think Professor Shashank Joshi sir has already touched on the susceptible population. I think in pregnancy and fetal development, when the baby, when the fetus is developing, they're very sensitive to this disruption by the endocrine chemicals, especially the prenatal exposure, neurodevelopmental concerns are there. Professor Sujay Ghosh sir, you would like to highlight about this pregnancy and fetal development and endocrine disruptors.
Right. Thank you, Dr. Vijay. So continuing from where Professor Joshi left, I think if you're looking at susceptible population, first, of course, is the pregnant mother, the fetus, and two other things. Number one, like he said, mothers with a background of autoimmunity, and more importantly, iodine deficient mothers. We still probably have a small proportion of people who are deficient. So this population will be most, vulnerable. One of the things that we've got to remember is that the placenta is not an effective barrier for EDCs. So a lot of these EDCs actually cross the placental barrier and cause irreversible damage to the fetus. That's something that we often actually do not think of. The fetus has very low potential to nullify the effects of the EDCs. Adults have a lot of enzymes which are mature, which might be able to metabolize some of these EDCs. Those would have been probably been taken care of in an adult, but not in a fetus. And importantly, when you're talking about the neurodevelopmental concerns, there is some data to suggest that there is lower IQ, learning disabilities, ADHD, and somehow we don't know why, but it's the male fetus which seems to be affected more. So there is data on that. So it's one area where we probably need more research and we probably need more data.
Thank you, sir. I think susceptible population, especially pregnancy, women have to be very careful about what they eat and about the exposure. So they need to be a bit more alert. So now we know that thyroid autoimmunity is the most common cause for various thyroid disorders. So the logical question comes, how do these thyroid disruptors affect the thyroid autoimmunity? And Dr. Sachin Mittal, you would like to highlight on this?
Yeah. So thank you, Dr. Vijay. So as we know that autoimmunity is perhaps the most common cause which is driving the increased prevalence of thyroid disorders, and there is a growing body of evidence, which I must say is currently not conclusive, not causal. It is more like an epidemiological evidence, which suggests that this is probably the exposure, higher exposure to EDCs, environmental endocrine disrupting chemicals like bisphenol A, phthalates, perchlorates, PCBs, etc. They do trigger a higher autoimmunity. It has been shown that those with higher exposure, probably there is a higher anti-TPO as well as anti-thyroglobulin antibodies, and perhaps some cohorts have had higher prevalence of these autoimmune thyroid disorders, and it has been seen more in people with like pregnant women, etc. But the results are more like heterogeneous. They are not like causality which is proven. What is the probable mechanism? Well, again, we are just hypothesizing. We don't have a clear-cut answer, but probably there is some degree of loss of immune tolerance to those thyroid antigens, and there are increased pro-inflammatory cytokines like interleukin-6, TNF-alpha, etc., which have been reported. Plus, EDCs have also been reported to probably bind to the thyroperoxidase as well as thyroglobulin and alter their structure. So as a result of which, probably an autoimmunity is getting triggered even more, and that is perhaps leading to an increased prevalence of autoimmune thyroid disorders. But yes, as more data comes, perhaps we'll be more wiser in coming World Thyroid Day celebrations.
Thank you, Dr. Sachin, for highlighting the various effects on thyroid autoimmunity. Now, coming back to the clinic, so suppose if a patient asks how to reduce exposure to endocrine disruptors to protect their thyroid. So I think already the previous speakers have highlighted that it's very difficult to give recommendations at present with scant evidence. But what practical evidence-based advice can be given? Sarita Bajaj, madam.
Thank you. Thank you, Vijay, for that question. So we should look at three aspects. One is protection of the lived environment, the consumer safety, and the occupational safety. So I think Shashank Bhaiya already mentioned the air pollution needs to be reduced, water pollution, soil contamination, food packaging, additives, household plastics, and toys. We should also keep that in mind. Cosmetics, pharmaceutical products, workplace and industrial safety. Now, think of it like a whack-a-mole problem. In other words, we have been able to successfully ban some products or phase them out, like DDT, organochlorine pesticides, PCBs, dioxins, fluorines, but the substitutes are far from perfect, right? So, but some of them have been replaced, which are equal or even worse health effects that are yet unstudied. And remember, BPA free is not EDC free. So I've given some of the suggestions, and there are a lot of regulatory recommendations like systemic monitoring, structured regulation, food consumer safety, waste management, public education, protection of the vulnerable population, like Joy just said, and Shashank also gave us the mother, pregnancy, and the child as well. Then cross-sector collaboration will focus on research. Again, a lot needs to be done there, and international collaboration. So these are the ways we can move forward and empower the healthcare professionals. You can do it education like we are doing today by webinars or seminars, information leaflets, and of course, inter-speciality collaboration. I think we have a good inter-speciality collaboration today. Thank you, Vijay. Thank you.
Thank you, madam. Then comes the question of nutrition. So can we give some selenium supplementation or ensure adequate iodinization to modify the thyroid effects of endocrine disruptors, Professor Shashank Joshi?
So this is a very controversial hotspot. I don't think iodine sufficiency is the order of the day, but iodine is a micronutrient which has to be optimally regulated. Too much or too less is harmful and hurtful. So that is as far as iodine is concerned. If you have a little excess iodine, it actually is deleterious to thyroid health in general, and thyroid pathology can be triggered. So there is very good data on this. So I would not put iodine too much. Iodine sufficiency is adequate, and except for areas of oncogenesis or oncology, where sometimes we have to give iodine-free environments, particularly pre-scan, there is no major role for iodine, except that iodine is very tightly, there is a narrow iodine window. And therefore, having that 75 to 150 micrograms of iodine is reasonable and sufficient. Selenium is only in two scenarios where selenium has a role in thyroid biology. One is in thyroid eye disease, and maybe some other role in thyroid autoimmunity or Graves' disease. But I think in both those situations, the verdict is not out. So I think I would be cautious as far as selenium is concerned for a routine recommendation on the selenium, except maybe there may be an adjuvant role with level E evidence in thyroid eye disease. So in absence of that, I would not put too much on nutritional modulation, but all I will say is try to be healthy as far as water is concerned, as far as the food is concerned, avoid ultra processed foods, and the basic food hygiene, sattvic foods, home cooked foods, not preserved foods, healthy foods, is something which is much more advice as a nutrient advice. Breathing fresh air, having some air purifiers, ensuring that you have boiled water. I think it's more than sufficient, and I would not put too much on it, except that iodine has a very narrow iodine window, and therefore we should not have excess, and we should not make that mistake of excess. And a lot of people give these seaweeds and the iodine-rich substances for many as quasi compounds and quasi pharmacy, and that should be completely discouraged. And I think the selenium is yet to arrive as a prime time nutrient, except maybe in the rare case of a thyroid autoimmune scenario or Graves or Bytopathy, where also I feel the data is very questionable, and I would not put a very high pecking order for either of these compounds. That's all I would say.
Thank you, sir. And thank you. Thank you for highlighting the role of iodine in selenium. So I think so much endocrine disruptors and thyroid disruptors are there in water and environment. So obviously the next question comes, regulatory thresholds, should we be more strict, or how do we go about this regulatory thresholds? Professor Sujai, sir?
Right. I think, every time you talk about any regulatory guidelines, we tend to criticize our own country. At least here we can say this is one area where even the world doesn't know what to do, really, realistically speaking. And still there is a disconnect between whatever the global regulatory requirements are versus India. And I'll give you reasons for that. Because, like Professor Shashank said, there's this fallacy of the safe threshold. We don't know what is a safe threshold for a lot of these EDCs, number one. Number two, we don't know about the dose response curve, like he was talking about, acute high dose versus chronic low dose. Do we really know? What's the cumulative dose? Do we really know? The third thing is the cocktail effect. You might have one EDC, when you add something else into it, and when you add the third one into it, the levels might not necessarily be the same across the the board. And the final fourth point would be the critical window of vulnerability. So what might be safe in a non-pregnant situation, in an adult, does not necessarily translate into safety in other situations. So because we don't know all of these four things, whatever we are talking about regulatory threshold, even if the government, say for example, asks the Indian Thyroid Society, can you please come up with a statement and tell us, do we really have enough evidence to make a truly scientific, concrete document and recommendation? So therefore, I think ITS should probably take the step forward in actually doing research.
Thank you, sir. I think we need more evidence to help the regulatory bodies to give some recommendations. So the last question, Dr. Sachin. So what do you think the future holds with regard to thyroid disruption? How can we improve the thyroid health?
So I think India has a situation where we always had a situation in terms of iodine earlier. On top of that, chemicals in pesticides and plastics and food packaging, they're increasingly disrupting the thyroid function. These all things we discussed in depth in last 30-45 minutes. The good thing is that the FSSAI, that is the body, proposed the banning harmful chemicals like bisphenol A and per and polychlorophenols from food packaging, which was like a first step. Second step would be trying to educate the younger population, especially the children, as to what is the right way, like stopping the use of plastic bottles, stopping eating at least hot food from taking at least food in a tiffin which is plastic tiffin, a hot food, to the school. That can be a small first step. Plus, more regulatory things obviously can be helpful, because things like safe water supply, safe agricultural produce is something which is easier said than done, but requires a lot of action, requires a lot of, and there are a lot of economic implications of that also. So that is something which is a bigger step, more difficult to do. The easier thing for all of us to do is to try to control what's in our control. That is try to have water which is not in a plastic bottle, maybe in a carry your own bottle to work. Try to have boiled water, and if it's possible, then avoid the kind of packaging which probably leads to disruption of the endocrine system. I think that is something which can be, which it's probably a long way to go, but one day at a time, one step at a time probably can be helpful.
Thank you, Dr. Sachin. I think this part we will skip because too short of time. I think all the practical messages have come through our panelists. So I would like to highlight that Endocrine Society of India has brought out a national white paper on endocrine disrupting chemicals, published recently. It's available online, so you can go through this for further details. So with this, I request our chairperson, Dr. Narendra Kotwal sir, who is a pioneer in environmental endocrinology, and he was one of the main authors of the white paper on this endocrine disrupting chemicals, to give the closing remarks.
Thank you, Dr. Vijay Bhaskar Reddy. I would like to congratulate all our esteemed panelists for educating us about the EDCs and on the thyroid health. And it was a very engaging discussion. It's very clear that right from we get up in the morning till we sleep, we are ubiquitously exposed to EDCs. So it is imperative on part of all of us to decrease the exposure to EDCs, which is difficult, but that is the call of the moment. That is all what I have to say. Thank you.
Thank you, sir. Dr. Arun Menon, sir.
Thank you, Vijay. I think everything has been discussed with the short time we have had. It's been very thought-provoking, and it is so nice to hear from everybody about what we need to do and the dangers that we are facing. So thank you once again.
Thank you, sir. Over to Dr. Ganavi.
Thank you, sir.
Thank you.
Thank you to all the chairpersons, moderators, and panelists for a very enlightening and engaging discussion. So the session definitely highlighted especially the relevance of environmental endocrine disruptors and their impact on thyroid health. So now we move on to the next important scientific session. So that is the monologue session. So we have with us the chairpersons for moderating this session, Dr. Minnie G. Pillai ma'am, who is the treasurer of the Indian Thyroid Society, and Dr. V. Kumaravel sir, who is the director and consultant endocrinologist at Alpha Hospital and Research Center, Madurai, as chairpersons for this session. So I request Minnie madam to introduce Dr. Amitabh sir, who is the speaker for the monologue. Over to you, ma'am.
Thank you, Ganavi. And we are moving on to a very important session, that is the role of radioiodine in the management of thyroid disorders. And to enlighten us on this, we have none other than Professor Dr. Amitabh Arya. He is Professor, Department of Nuclear Medicine at the esteemed Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And he has many honors to his credit. He is the third MD in nuclear medicine in India. He is the first Indian to receive the Fellow of the Asian Nuclear Medicine Board. And he is the first Indian selected for the International Fellowship at Seoul National University Hospital, South Korea. And he has over 30 years of experience in patient care, teaching, research, and so many publications. And he has contributed to nuclear medicine literature and many academic books also. And he is also associated with international research collaborations, including IAEA funded projects. Over to you, sir.
Can you hear me? Good evening, everyone. Can you hear me, please?
Yes, sir.
Yes, ma'am. Good evening. Thank you. I would like to thank Dr. Pramila for inviting me for this August audience. And the topic I'm going to start now. It's a very important topic regarding radioiodine and its effectiveness and timing effectiveness in hypothyroidism. So, yeah. Can you see the slides, please?
Yes, sir.
Okay, sir. So we all know about the causes of hypothyroidism. I won't go into detail about it. And we know Graves' disease is an autoimmune disorder. TSH receptor stimulating body, hypersecretion, hyperplasia. These are all the different factors related with Graves' disease. And female to male ratio, as we all know, is 7 to 10:1. You have proptosis, ophthalmoplegia, congenital irritation, hair loss, and so many things related with Graves' disease. And 20 to 40% of patients have ophthalmopathic Graves' disease, and 3 to 5% have severe symptoms presenting with intense pain, double vision, or loss of vision. Ophthalmopathy can also occur in absence of hyperthyroidism. As it does in other autoimmune disorders, remission after ATD is defined as being euthyroid for at least 1 year after the treatment was stopped, and this occurs about 50% of patients. Frequency of long-term remission has decreased over the past 30 years because of the intake of dietary iodine intake. Antibodies, as we all know, determination of antibody. Yeah, please.
You can go to slideshow mode.
The chat has not come. Sorry.
Yes.
I think I have
slideshow. Yes.
Slideshow. Yeah. 1 second.
It's not on full screen.
It's not coming. Just a second.
Down you can click, sir.
Is it coming?
Not yet, sir. I think you
No,
have to
just
click.
1 second, 1 second, sir, please.
Second. The top part next to animations slide.
Yes, I'll just. Adya, slide show bani Adya. Adya. One second, sir. Just 1 second. I'm extremely sorry. 1 second.
Okay, sir. We can see the slides very well, even as it is.
Can you see it now, sir?
Yes, sir.
Yes, sir. Yes, thank you.
Yes, okay.
Sorry for the interruption.
Actually, I'm extremely sorry.
Sure.
Sorry. So, okay. So determination of antibody titers are supporting evidence. And as we all know, more than 95% have positive TPO microsol antibodies, and more than 50% have anti-thyroglobulin antibodies. Prevalence of anti-TGATB is higher in thyroiditis, and titers tend to increase post-radioiodine therapy. That increase in antibodies are thought to be due to exacerbation of autoimmunity, the release of destroyed cells, and hence the antigens activated immune system. The antibodies may explain the worsening of ophthalmopathy post-radioiodine therapy. And we all know we have antithyroid drugs, we have surgery, we have radioiodine. Antithyroid drugs there'll be reduction in production of thyroid hormone, debatable effect on immune system in bringing remission. Surgery will definitely reduce the mass of thyroid tissue, but radioiodine also it is known as surgery without knife. So it will also reduce the mass of thyroid tissue. And radioiodine is preferred method in various countries, 69% as per the ATA. European, they say 22%. India, it is not documented. Japanese Thyroid Association says 11%. ATDs 30%, 35%, same in ATA. European 77%, 88%, respectively in the various countries. Side effects of ATDs, as we all know, abnormal sense of taste, pruritus, pathalgia, urticaria in 1 to 5%. Cross reactivity is seen up to 50% of patients between different drugs. Agranulocytosis occurs within 3 months. Incidence is 0.2% methimazole and 0.5% in PTU. Commonly seen in doses above 30 mg per day, and hepatotoxicity in 0.1 to 0.2%, and vasculitis. Now we come to my topic, radioiodine ablation. As we all know, Dr. Paul Hertz started it for the first time after research in rabbit, and in 1942 it has been used for treating hypothyroidism and also in thyroid cancer, primarily papillary and follicular. And it is a gamma beta emitter, 364 kV, what we use for the treatment for thyroid disorder, and beta emission is 192 kV. Half-life is 8 minutes, and penetration range is 2.2 millimeter. While radioiodine therapy, it carries a small risk of hepatic failure and agranulocytosis, chance of relapse when discontinued, multiple years of treatment, surgery, risk of recurrent laryngeal nerve damage, definitely in the hand of an inexperienced surgeon, and hypoparathyroidism, and sometimes failure. Now, the thyroid here concentrates iodine by means of sodium iodide importer, first characterized in 1996. Also present in glandular and mucosal tissue, choroid plexus, ciliary body of eye, and placenta. And this is the mechanism of uptake. I won't go into the detail. How it goes into the thyroid follicle, we all know about it. Pre-treatment preparation, we do TFT. Women of childbearing age should have documentation that they are not pregnant. Routine pregnancy testing is offered prior to radioiodine therapy, and we rule out silent thyroiditis and factitious hypothyroidism. History of IV contrast, cough syrup, amiodarone intake is also seen as a pre-treatment. Is thyroid scanning necessary? Coincidental cold nodule in Graves' disease have to be evaluated to rule out cancer. Scanning helps identify these nodules. Surgery is a best treatment for patients who have these cold nodules if thyroid 3 or more. This is a picture of a gamma image with a cold nodule. Then you have Graves. How you have incidental findings of pyramidal lobe, hot and cold nodule, a toxic medullary goiter, hot nodule, suppression of remainder of gland. You can see here on a thyroid scan in autoimmune nodule, and thyroiditis, where there's no visibility of the thyroid gland. Factors: dose of radioiodine, uptake by the thyroid, half-life, size of thyroid, radiosensitivity of the cells. Antithyroid drugs are the drugs like imidrone and iodine. Neurodiagnosed patients with mild hypothyroidism and no eye signs, radioiodine ablation can be performed directly. Antithyroid drugs are administered to patients with severe toxic symptoms to return the patient to a thyroid state. Large glands and severe hyperthyroidism, concomitant heart disease, patient at risk of exacerbation of symptoms due to radioiodine therapy. And this is what we recommend for the withdrawal for antithyroid medication and for thyroid, synthetic thyroid hormone, expectorants, Lugol's iodine, topical iodine. This is the list. We all know about it. And this is what we advise the patient for 7 days after treatment. First into us, avoid as often as possible, flush toilet, wash hand, do not share eating utensil or towels, sleep in a separate bed, avoid intercourse. 4 to 6 weeks follow-up is required, and then do not get pregnant for at least 6 months. Dosage calculated according to the size of the gland, fixed dose, low or high, multiple small doses. Relevance, we don't have a problem with low dose is 25% of patients require a second dose and 5% required a third dose. And this is as per the what we calculate, and desired in microcurie retained per gram at 24 hours. And average dose is here, you can see. And the RADS is mean is how much radiation are given to the gland. And this is the calculation we do. In India, primarily, we don't do dosimetry. We use the fixed dose regimen, and most of the centers do it. But in other countries, they do a proper dosimetry, then they go forward. And this is how they do the dosimetry. Administered microcurie, RAD desired, multiplied by gland weight, multiplied by 100, and the uptake they see. And then this is how they calculate about the dosimetry. We do a fixed dose regimen in our country, 5, 10, 15 millicurie of fixed dose compared to calculated dose in patients. Graves, toxic nodule, MNG, and success rate, failure rates, and hyperthyroidism is similar. About 80% success rate are achieved if more than 200 grade thyroid doses are delivered. Here, I would like to tell you that in autonomous functioning thyroid nodule, we give up to 25 millicurie because it is radio resistant. And Fido recommended for low 24-hour radioiodine uptake less than 50%, large goiter, severe thyrotoxicosis. It has got a more rapid intrathyroid iodine turnover, toxin or goiter, 25% more dose, as I told you earlier, is needed. And patients treated with antithyroid drugs, pre-treated with radioiodine, those at risk due to persistent disease. This rapid turnover of iodine, higher uptake at 46 hours, reduced uptake at 24 hours, seen in patients with long-term ATDs, necessitates high dose for achieving adequate control. Reduced biological half-life of iodine, 0.2 millicurie per gram dose might be necessary. Previous failure does not lessen the chance of success on retreatment. And then when we see the improvement, we see the initial level of thyroid function, size of thyroid gland, rate of intrathyroidal turnover, dose of radioiodine administered. 50 to 75% of patients have normal thyroid function and some shrinkage of the gland by 6 to 8 weeks of administration of radioiodine. Course, return to ethyroid state status requires at least 2 months. Transient hypothyroidism develops in 10 to 20%, but thyroid function is regained in 3 to 6 months. 50 to 80% reduction in size of thyroid gland occurs. Follow-up, as per the book of Williams, it says every 4 weeks, merely to identify early hypothyroidism and treat them. The root says 8 weeks in a relative trade-off, 12 to 16 weeks ideal time. But in our setup, and mostly in the nuclear setups, we call after 4 weeks. And we always tell to the patient, if they have any discomfort, any problem, they can come earlier. Side effect is inevitable, is hypothyroidism is a consequence of radioiodine, because radioiodine will not be sparing some thyroid follicle and leaving the less. So must be desired consequence and all the, we always tell the patient about it, because managing hypo is easier than hyperthyroidism, which has so many plethora of various disorders associated with it. About 20 to 40% of patients become hypo at the end of first year. The rate of occurrence of hypo depends on the dose administered and serum TPO antibodies. Hypothyroidism, about 90% of patients develop within the first year, continuing rate of 2 to 4% per year. Hypothyroidism is also related to the antibody levels, apart from the dose of radioiodine. Therapy with antithyroid drugs immediately after radioiodine reduces the chance of hypothyroidism, but there's an increase in the chance of treatment failure. Transient hypo occurs about 2 months after therapy, lasts for 1 to 4 months. Serum TSH levels are low. Therapy may be withheld for 1 to 2 months unless the patient is unacceptably symptomatic due to transient thyroid injury or persistent TSH suppression. Progressive ophthalmopathy occurs in 15% of patients. Smoking is a factor. High TSH antibody, pre-existing eye disease, severe thyroid disease manifestation, and have a high likelihood. And whenever we have such a case of ophthalmopathy, we always consult with our eye surgeons and we put them on steroids before and after, and we later on taper it. A prospective study showed that ophthalmopathy developed worsened in methimazole 10%, radioiodine 16%, and surgery 16%, radioiodine 33% during 2-year follow-up. This may be related to hypothyroidism developing post-radioiodine therapy. Adverse effect, patient treated with radioiodine showed no tendency to develop thyroid cancer, leukemia, reproductive abnormality. Their children may have no increase in congenital defects or evidence of thyroid damage. Like in a woman receiving 10 millicurie of radioiodine, the ovaries would receive 1 to 3 rads of radiation. This is equal to dose received in IVP or barium enema. The genetic risk of radioiodine is less than spontaneous rate of genetic abnormalities, 0.03% versus 0.8%. No high risk of genetic abnormalities in women who received radioiodine in childhood. Allergic patient in patients with allergy to radioiodine, radioiodine can be safely administered because the mass of radioiodine administered only 1 microgram. Milder side effect is radiation gastritis, anterior neck pain. Very rare side effects are hypoparathyroidism, hyperparathyroidism, vocal cord paralysis. Worsening of symptoms, transient increase in the circulating thyroid hormones may occur. They're usually clinically silent, especially when treated with beta blockers. Now coming to toxic nodules, surgery in patients with significant airway obstruction and in those with high risk of harboring malignancy, they are more radio resistant. 150 to 300 gray have been delivered. 200 microcurie per gram corrected for 24-hour uptake is reasonable. Dose treatment failure are common if less than 10 millicuries administered. For toxic nodule, rest of the thyroid is suppressed, still may receive dose up to 32 gray. No increased risk of cancer. Hypothyroidism is less frequent. Before therapy, TSH should be measured and the thyroid scan should be performed. To exclude uptake in the remaining thyroid, nodule size frequently reduces post-treatment. In toxic MNG, secondary development of autonomous nodule in MNG due to somatic mutation in TSH receptor gene 60%. Patients usually older than 50 years, mainly involves the serious. 150 gray may be adequate to resolve hyperthyroidism. 100 to 200 microcurie per gram has to be administered. So, conclusion, based on current evidence, a fixed dose of radioiodine is effective in achieving treatment goals. Antithyroid medication should be stopped 3 days prior to therapy and resumed after radioiodine if necessary. Patients with mild TO may benefit from a course of prednisone to prevent worsening or progression of disease. Hypothyroidism need to be detected early and treated to prevent progressive TAO. Lifelong follow-up is important to ensure that the recurrence of disease or hypothyroidism can be treated. In conclusion, radioiodine is a safe and effective modality for treatment of Graves' disease. Thank you.
Thank you, Dr. Amita Parya. I think you have covered the whole focus of role of radioiodine in a very short span.
Thank you, sir.
I think you have discussed the varying dosages in Graves' disease and have you seen in your practice longer the duration of diabetes, whether the dose increases for patients?
Sir, I'm not able to hear. There's some.
I'm trying to.
No, sir, I'm hearing you, but a lot of interplay is there, so I'm not.
I just wanted to know, in
Yes,
your
sir.
practice, longer the duration of hyperthyroidism, whether it could be
Yes, sir.
topic, nodular, or multinodular goiter, do you feel the dosage of radioactive iodine increases?
Yes, sir. Yes, sir. So actually, what happens, like in our setup in SGPJ, we have a good we have with ophthalmics, endosurgery, endomedicine. So we have a teamwork. Actually, what happens in patients who are coming from outside, therefore on antithyroid drugs for 10 years, 12 years, 15 years, then the effectiveness of radioiodine is very. It takes time, sir, for the effectiveness to come, and then along with it, they have got ophthalmopathy. It is very common, and then we send to the ophthalmic surgeon, then we put them on steroids and taper it. So is earlier the better. And the best part is initially you go to your endocrinologist, the Graves disease, and go with the treatment of antithyroid drugs. Suppose you have relapse rate is high, then you send to for radioiodine, because radioiodine, I never tell to patient you straight away come to us, don't take ATDs. No, you please go to an endocrine surgeon, endocrinologist, get antithyroid drugs. If it works, good. If it doesn't work, then come to us.
Yeah, thank you, Dr. Professor Amitabh. Mini, do you
Yes,
have
sir.
anything to add, or?
Nothing.
Okay.
Excellent talk, sir. Thank you.
I'll hand over the forum to Dr. Ganavi. Over to you.
Yes.
Thank you, sir. Thank you, sir, for the very excellent and highly informative presentation.
Thank you, ma'am.
Definitely, practical insights into radioiodine therapy and thyroid disorder management definitely has been valuable for all of us, sir. So we
Thank you,
also
ma'am.
thank our respected chairpersons for conducting the session so effectively. So moving on towards the next session, we have the session on thyroid nodules, how to avoid both overtreatment and mismalignancy. So which is a very important and clinically relevant panel discussion. So moderating this session is Dr. Roma Pradhan, Madam, who is the Associate Director of Endocrine and Breast Surgery at Medanta Hospital, Lucknow. Ma'am is an accomplished endocrine surgeon with extensive experience in thyroid cancer and parathyroid surgery. So delighted to welcome you, Madam. So I request Dr. Roma, ma'am, to introduce the rest of the panelists and hand over the proceedings to Madam for the moderation of this fascinating panel discussion.
Yes, thank you, Dr. Ganavi. And thank you, Team ITS, to organize this World Thyroid Day and giving me this opportunity to have the panel discussion. And I'm really fortunate to moderate this panel discussion, as we have a lot of esteemed panelists in this panel discussion. To start with, can we share the CV slides, please? Yeah. So to begin with, we have Professor Amit Agrawal, sir. He, of course, needs no introduction. He's the Director of Breast and Endocrine Surgery at Medanta Hospital, Lucknow, and he's teacher to almost all the endocrine surgeons who are working in India. I think that is the best introduction that I can give to him. Next, please. Then we have Dr. Himgarish Rao, he's also Joint Secretary of ITS and Professor of Surgery. And he's a part of ITS team, of course. And he has a lot of publications to himself. Welcome, Dr. Himgarish. Then we have Dr. Ritesh Agrawal. He's a well-known endocrine surgeon from Mumbai. And he's, of course, the first MCH in endocrine surgery in Mumbai, and he has a lot of patients there. And he's doing really good. Welcome, Dr. Ritesh. Then we have Dr. Naval Bansal. He's a well-known endocrine surgeon from Chandigarh. He's my batchmate also. And welcome, Dr. Naval. Then we have, I think Dr. Vineet is not able to join us because of some personal commitments. Then we have Dr. P.K. Jabbar, sir. He's Director and CEO of Indian Institute of Diabetes. He's Senior Consultant at Indian Institute of Diabetes, former Professor and Head Department of Endocrinology at Trivandrum. And he's also former Principal, Government Medical College, Trivandrum. Welcome, sir. Then we have Dr. Rajesh Rajput, who's Director, Department of Endocrinology at Medanta, Gurgaon. And he's a well-known endocrinologist. I think he needs no introduction. So can we start with the panel discussion now? I'll just share my slides. Are you able to see my slides?
Yes, please.
Yes, Roma.
Panelists? Yes.
Yes.
Yes. So we know that today is the World Thyroid Day, and balancing over treatment and malignancies, thyroid nodules is really important. And going with the theme of Know Your Thyroid, we should know as to what treatment we have to offer to our patients and what's the best management for these thyroid nodules. We all know that thyroid nodules are extremely common, while clinically significant thyroid cancer is relatively uncommon. Modern thyroid practice therefore requires a careful balance between avoiding unnecessary cytoFNACs and surgery while not missing the biologically important malignancy. So today we will discuss how ultrasound stratification, cytology, molecular testing, and active surveillance have changed this balance. So basically, the patient's worry and also the clinician's worry revolve around these two main questions, that we need to exclude thyroid malignancy and what is the optimal surgical management. So the first part of this discussion will revolve around one of the goals, that how do we use imaging effectively to reduce unnecessary biopsies without missing high risk features. So for this first uh, question, can I ask Dr. Rajesh Rajput to answer this question? How do modern risk classification system like ACR, TIREDS, and ATA guidelines actively prevent overtreatment of benign nodules? How do you manage such patients that you get in your OPD?
I think you have already, Roma, prepared the next slide to answer this question. And
But it will be easier if you explain it in a simple way for our audience.
First of all, throughout the country, radiologists, now the things are changing, at least in government institutes and obviously in corporate setups. Now, ultrasound thyroid report for thyroid nodule is given by classifying the nodule into thyroid classification. Still, unfortunately, large number of private reports which we are seeing, they are not doing ultrasound according and not giving report as per thyroid classification. So the first problem when patient comes with an USG report to us with a thyroid nodule, we cannot make out anything out of it. Whether actually patient need a FNA or does not need an FNA. That is the first biggest challenge in our country till now. So what is actually needed is that it should be actually mandated that every ultrasound thyroid nodule report has to be given in a format of thyroid and risk stratification because depends according to that. Now Roma has actually already shown you the slide. So whenever we see a patient of thyroid 0, thyroid 1 or 2, we actually we say, please do not worry anything. This is mostly a benign nodule and you do not need to do anything. But if the nodule size is big, and if actually the patient is worried cosmetically, which is quite common in young age female patients, then we now have non-surgical methods also to take care of those nodules, which at least at Medanta Gurugram we are doing by radiofrequency ablation, by doing alcohol ablation. So on a given case, whether it is purely a cystic nodule, whether it is a cystic solid mixed nodule, so it all depends on that. And you have wonderfully actually highlighted everything in these slides. So you have done a good homework. So, so actually it all depends on that. But definitely, if somebody ultrasound report comes out and it is in the 4 or 5 or suspicious category, then probably it makes a case then where we should tell patient the real risk of malignancy. So therefore, somebody who is coming to us with a thyroid nodule, which is 1 or 2, we simply say, even you does not need actually an FNA. Please, we try to assure them. But since today's era, people sometimes come up with so much of chat GPT knowledge and even the social media knowledge, If they persist, no, we want to be sure, we want to get an FNA, then only we will ask, okay, if you are willing to go for an FNA, go for it. Now, size is another criteria which you have highlighted actually here. Now, the past and new classification, there is a small change, but definitely anything which is less than 1 centimeter, micro nodules, the until and unless there is a very high risk, there is no point in probing or needling those things, because it has been shown that false negativity is equally high. And the long-term prognosis of microcarcinoma is, is fundamentally very good, very good. So therefore, until and unless there are USG evidence of very high risk suspicion, and where patient comes in thyroid 4 and 5, less than 1 centimeter, we usually avoid. So therefore, low suspicion nodule, anything which is more than 2 centimeter, we usually avoid FNAC. Pure cystic nodule, we avoid FNA. Spongiform nodule, we avoid FNA. So these are few things now which has been stratified, but the only problem is lack of awareness among our sonologist as well as our general practitioner, because still these things are not followed throughout the country uniformly.
Right. Thank you so much, sir. This was made it very easy for us. And so I'll come to a case after this. A 30-year-old doctor who presented with a small swelling in front of the neck, which she noticed actually. It was 7.9 mm, TIRAX 3. So now for this, I would like to ask Dr. Jabbar, sir, what will be your approach? This is the detailed ultrasound report of this patient.
See, I think in continuation with my friend Dr. Rajput's discussion, may I add few more points to that? Always ultrasonogram is very important. There is no doubt about that. Nowadays, when we were students, ultrasound was not that important. But now, even see in almost all departments and all clinics, we have sonology machine. But before going to the procedure of ultrasonogram, I have a feeling that always we should look into the clinical profile also. Thyroid is there, thyroid system is there, size cutoff is there, that's true, agree. But in addition to that, what I feel is the clinical profile is very important. Here you have a patient. What is the importance of this history? 38-year-old, I think, say what I understood is a male patient or female?
Lady.
Lady, okay, that's fine. And the size is 7.9 millimeter. Yeah,
yes.
Millimeter. So, and thyroid is 3. If you precisely speaking, there is nothing to worry about this case, okay? As the AT recommendation goes, this you can observe, that's true. But I have little concern also. Of late, we are definitely looking into the subcentimetric nodule, how to sort out. So when we looked at our data, certain clinical and radiological pictures or features are really confusing and giving little unrest also. Like, say punctate calcification in a patient with the hypoechogenicity, that is important here. So if the hypoechogenicity, I have entered microcalcification, I have some concern. So precisely for this type of patient needed, but I will look into the other features, and I don't have any needle cytology also to rule out, because if she's a BAP patient, if something happens, and there are concerns. So these are my points. As per recommendation, there is no need of cytology, but there are certain concerns. I may suggest for a needle cytology in this type of patient.
Yes, perfectly, sir. So this patient actually got an FNA done, and it was Bethesda 5, which was suspicious of PTC. She underwent hemithyroidectomy, classical PTC with no nodal mets. The only thing I would like to mentioned here, there was a focal bulge of the nodule is seen into the anterior strap muscle with interruption of hyperintense thyroid cap. This was one of the factors which did. So there are, so when should a clinician intuition override an automated or standardized ultrasound risk score? So for this, I would like to ask Amit sir to, when would you order FNA for such cases which are like benign, thyroids 2, thyroids 3, low suspicious and less than 1 centimeter?
Yeah, hi everyone. So I think our country is really passing through a very heterogeneity of the availability of ultrasonologists. On one hand, we want to follow our ATA guidelines, but it's difficult to apply in our set of patients because you don't have the trained ultrasonologist available. What I'm concerned, like in your case, is what to do of a Thyroid's 5 millimeter nodule. Would you like to biopsy or not? We have seen that if you biopsy it, will come out to be a PTC. Now, according to recommendations, it's not recommended that you do a FNA from a 5 millimeter nodule. But many of us would not really follow that guideline and would like to FNA if you're confident about your ultrasonologist. Now, coming to the question which Roma you asked, recommendations are thyroids 1, 2, 3, no need for FNA. But the clinical context is important. If the size is large, patient has compressive symptoms, the family history of neck irradiation is, of course, you don't find these days, but as a classical teaching, if there's a history of irradiation, MEN1, if there's a history of men. So these are the situations where you would still like to do a biopsy, despite the recommendation that TR1 to 3 you need not aspirate. One other important thing is that sometimes you get a suspicious node, a cystic node along with the, thyroid's 3 lesion. These suspicious nodes, if you get, especially if they're cystic, you would like to do an aspiration. So I think a clinical context, as you rightly mentioned, is very important. We can't just go by the guideline. And each clinician will develop his own sense of picking up those red flags, and then you will proceed accordingly. So I think we should not really follow the guideline very strictly. Take each case by case and then decide about aspiration and subsequent management.
Yes, sir. Perfectly taken. So we have to find, as sir mentioned, the red flags. We have to see when to FNA them and counsel the patient accordingly. So coming to my next case, a 42-year-old gentleman who was a family member of one of our colleagues. Ultrasound showed a 10.7 mm thyroid's 5 nodule, and left lobe also showed subcentimetric nodules, which were thyroid's 3. FNAC was done twice, so it came out to be Bethesda 3. So what options do you have, Dr. Ritesh? Would you like to comment?
Yeah, hi Roman, thank you so much. And thank you ITS for giving us this opportunity for highlighting the management of thyroid nodules. This AUS is a very dicey thing. Are you able to listen me, Dr. Roma?
Yes, you are very much audible.
Yeah, okay. So this AUS is a very dicey thing. Though literature says that up to 5 to 15% chances of malignancy are there in such kind of nodules. But our experience is that it's quite higher when we had operated on such AUS patients. So we take all these AUS and follicular neoplasm, that is category 3 and category 4 Bethesda, with a pinch of salt. And then we discuss with the patients that, see, this is a nodule, and either can follow it up or you can do at least a lobectomy or a hemithyroidectomy to confirm the disease, whether it is a benign or a malignant one. Most of these patients themselves desire surgery because they do not want to take any, though the prognosis is very good, but they do not want to take any kind of risk for future malignancy. So they'll end up with a surgery only. But before surgery, as usual, that all the workup for thyroid nodule is being done. And if surgery is done, then we discuss with the patient that what kind of surgery you prefer, either hemithyroidectomy or total thyroidectomy. It all depends upon the patient's with both choices are optimal. Hemithyroidectomy is sufficient because even with such small malignancies, as half the lobe of the thyroid can be removed safely, and the patient can continue with the half of the thyroid lifelong.
But Ritesh, the other lobe also has subcentremic nodules, though they are Thyroids
Yes, sir.
3. Would you
Yeah.
take that into account?
Definitely. So that is why I'm coming to the thing. That nodules are on both sides. So patients' demand is also important. Patients wish also important whether they want a hemithyroidectomy or a total thyroidectomy, especially when the disease is benign one. So I give them the option of hemi and total both. If I am contemplating hemithyroidectomy, then we prefer frozen section biopsy in every patient, so that
No,
we are
Ritesh,
sure.
I think,
But
sorry, I'm
but
interrupting.
Amit,
So,
but Amit,
no, yeah, Rajesh.
why does not such patients FNA can be subjected to molecular testing?
Yes.
No,
Now
no,
we,
that's
So
what I
that
was
is the
coming
next
to.
step. We were
Yeah.
coming,
So
was
before
coming to that.
surgery, the patient would like to, there are two questions. First, should you have aspirated if the patient comes to you with a 10.7 millimeter nodule or subcentimeter? Would you aspirate or not? What is the
Yes,
consensus for
Thyroid's
panel?
5, which is
It is
thyroid.
Thyroid 5. So it demands for itself that aspiration should be done. It is Thyroid 5, and the other side is Thyroid 4. So FNAC is the
3.
optimal initial. Thyroid 5, the sonography right nodule is Thyroid 5.
Yes. So
No,
Thyroid's
left is
5
Thyroid 3.
nodule definitely requires FNAC, and
FNAC,
even
that is for
Thyroid's
sure.
4 can be subjected to FNA.
Yeah,
So
and as
next,
Dr. Rajesh and you also pointed out for the molecular testing. See,
No,
molecular
sorry,
testing can be done.
I'll just interrupt, Recommendation says that less than once, suppose this was 10 millimeters, 10.7 in 10 millimeters, Thyroid's
Yeah.
5.
Yeah.
What is the consensus the panel? Would you aspirate?
sir, Dr. Amit, Thyroid 5, any size.
I will not be.
No, Rajesh. ACR recommendation says less than 1 centimeter, even if it is Thyroid's 5, because there the concept is that they will do surveillance if it comes out of PTC if somebody aspirates.
But that is important in those cases where a close follow-up is possible.
That's what I'm
In our
saying.
country,
So
where
that's we have to
patient is
discuss.
lost to
That's we have
follow-up.
to discuss.
Yes,
The
yes, yes.
recommendation says don't do FNA, but in our setting, we will do an FNA.
Yes, we will do an FNA in
we
our
all
setting.
agree to it. All the
Yeah,
panelists agree
we
that
are
we
all
should do
discussing the
FNA.
same direction only. There is no much difference.
Yes.
Okay.
Now question comes for the molecular testing, as Dr. Roma asked. See, molecular testing, number one, it is available at very few places. It is not a universally available thing. Second, it is quite costly and all the patients are not affording it. Third, the sensitivity and the specificity. Though the sensitivity is not very high, and still after doing the molecular testing, if the report comes as negative, chances of malignancy itself are still not ruled out. It can still be malignant, especially in such kind of nodules. So molecular testing is plus minus. It is not a sine qua non that if it is negative, the malignancy will not be there. No, malignancy can still be there if it is negative.
No,
Yes, if it is
Ritesh.
positive.
So
Yeah.
Dr.
suppose
Nawal,
if
would you
cost
like
is not a
to?
factor and it is available, would you like to do a molecular testing or not?
I will give the option to the patient that whether you
Yes.
want a surgery or you want a molecular testing.
So we have to
If the
start
Dr.
with
Nawal,
that.
would you like
Yes,
to?
yes. Hi, Roma. Hello, everyone.
Yeah.
In
Hi.
my opinion, since the ultrasound also showing moderate to severe suspicion of malignancy, as well as FNSC is again ATPR. So I would like to go for a surgery without default, and I'll prefer doing a total thyroidectomy. That's my practical approach. We don't have a facility for molecular testing, and probably I have no experience of doing subjecting these patients for a molecular testing. But given the context, 42-year-old lady, Thyroid 5 on one side, Thyroid 4 on the other side, and FNA of AUS, majority of us agree. Whatever the reporting we are getting in our setup, be it a FNSC or a ultrasound, it's not that accurate as compared to the Western countries. So if it is a suspicious, I'll like to go for a total thyroidectomy without any.
No, Naval, the patient usually asks, sir, with the Thyroid's 5, what is my probability? And with the OS FNA, what is my probability of having a cancer? So you
Yes,
would say
Thyroid 5
25 to
around.
30%.
Yes, sir. In
So
EAUS,
the patient will ask, sir, is there any way to increase this probability so that I can take a decision to undergo surgery? So obviously a
definitely
molecular
we
test
can.
would increase the probability.
Yes, definitely we can go ahead, sir. But in my personal opinion, I don't have much experience of using this molecular testing, and probably whatever the context and whatever the facilities we have, definitely this is what we can offer. But if the facilities of molecular testing is available, definitely we can go ahead with this.
So for this case, I must mention he was a family member of one of the doctors, the colleague. So of course we have to give the option to the patient as to what is available and what is the way forward if they're asking. So this patient we did molecular testing in this, and it came out to be BRAF positive. So we went ahead with surgery, of course, thinking it to be multiple nodules. So we went ahead with total thyroidectomy, and the lateral nodes came out to be positive. Patient underwent TT with CCLND with right side selective lymph node dissection with neuromonitoring and autofluorescence. This was the biopsy report. Any more questions?
In this patient, had you gone back to the sonography report, whether there was positive lateral lymph nodes or not on sonography?
No, none of them were suspicious.
Okay.
Yes. So coming to another case.
Amit sir, I have
Yeah,
a
Dr. Jabbar.
doubt in this case. See, you have reached T4 and T5, T4 and T5, right? Okay, both lobes. Okay, what way? Suppose if the molecular genetic studies are negative, okay, in what way we can change our decision now? Molecular, you are asking for molecular genetics or study.
Then we come to a situation as if the molecular test was not available. Suppose molecular test is not available and you have a TYRX 5 1 centimeter nodule.
Correct.
You would go ahead with surgery or you would observe?
I don't want to take any risk because I will go for surgery here.
Exactly. So see, molecular testing, if it is positive, the chances of false positive are very low. So the patient is convinced, you are convinced. See, this patient, the lymph node turned out to be positive also. So, you couldn't have left the disease.
Correct.
So it helped the patient to take a decision to go ahead for surgery.
That's right. Perfect.
And the doctor decided to do a total thyroidectomy rather than a hemithyroidectomy. So these are the advantages. So see, we are talking of modern thyroidology in 2026. We can't practice thyroidology of 1990s. As in other areas, we have to take advantage of the modern tools which are available to us. There is no harm in that. 18,000 rupees is not an expensive affair.
So here is my question, sir. That how much is the sensitivity of this molecular testing in your setup, sir? That how much is the positive pickup rate in your setup? Yeah.
Yeah, Dr. Roman.
Yeah, we'll come in the following slides.
Sure.
I think you'll understand with the following cases. So there's another case of 24-year-old girl with left STN. FNAC was done at SGPJ Bethesda 4. Ultrasound we did here, it was TYRADS 3. So patient wanted to undergo robotic thyroidectomy because she wanted no anterior neck scar. This is one thing. So what next? Bethesda 4.
If it is a Bethesda 4, that is a follicular neoplasm sonography status 3, 20 feet. What was the size of the nodule?
4.2 centimeters.
Hemithyroidectomy will be sufficient, and then histopath or the frozen section biopsy will determine the future course.
Yes. So since the patient was from Canada, so we went ahead, of course, with molecular testing. And this was the molecular testing. It was HRAS. So the probability of malignancy in these testing, every gene has different rate of malignancy that they may harbor. So the only issue with this patient was she never wanted an anterior scar. Suppose we had done hemithyroidectomy robotically, and then later on it came out to be positive, and we had to go again for total thyroidectomy. That was little impossible in robotic thyroidectomy. We usually do not reoperate on such cases. So that was one of the question which was difficult for us to decide. So
Can I add, Roma here?
Yes.
I want to answer Ritesh's question, So the molecular testing stratifies into a low risk gene, a moderate risk gene, and a high risk gene. So the high risk gene is TERT. So if you get a high risk gene, there is more than 95 to 98% probability of malignancy. The moderate risk is a BRAF gene where you have a 85 to 90% probability of malignancy. The low risk gene is the RAS gene where the probability is 40 to 50%. Now, once you have this kind of a testing, it's easy to discuss with the patient the extent of, first of all, whether surgery is required or not, and whether the extent of surgery is required. What should be the extent of surgery? So I would encourage our endocrine surgeons and endocrinologists to try and generate an experience of molecular testing and see how useful it is in their practice. So it's one point we have to start using this tool. So I think it's the right time, whenever the patient can afford it, try to use this in Bethesda 3 and 4, and then generate your own experience based on this stratification of the gene to help you take a decision for surgery and the extent of surgery.
So
Can I add,
88-25
Amit?
guidelines.
Amit, can I add?
Yes, Rajesh.
Actually, let us clarify it, those who are listening to this webinar, why we are ordering molecular testing. Now, whenever we are ordering molecular testing, we have to understand the sensitivity and specificity. Overall, sensitivity is more than 90%. Specificity is little bit less, 60 to 70%. Now, we are ordering this just if sensitivity is high, then the negative predictive value become more. So if the test is negative, patient can be assured that this is not a malignant nodule. Now, then the onus lies on the patient if he still wants to go for the surgery. But if it is positive, remember, if it is positive, it does not mean that even after operation it turned out to be a malignant nodule. Sometimes even after, when these are positive and when patient is operated, still the report, histopathology report, does not show a malignant nodule. So therefore, the importance of this lie in ruling out, telling to the patient. So sensitivity
Dr.
of all tests are very high, more than 90%. But only problem is they are not freely available in our country. They are selected available. But now there are large group of patients who read Chat GPT, who are on social networks, who themselves come prepared. And this we face day in and out. When patient comes to us, today only I have a young female, 27 year of age. They asked, why cannot we go for molecular testing? So therefore, we have to be prepared for that. And if there is a doubt, there is no harm in asking for molecular testing. Surgical operation decision can be taken a week later on.
Yeah, well said, Rajesh. That is why I told
I
you
have a comment,
stratification.
sir.
If you get a RAS gene, you say there is a 45-50% probability. But if you're getting a TERT gene or a BRAF gene, probability of malignancy is very high and
Yes,
actually
yes,
happens.
yes.
I have a comment, sir, on Dr. Rajesh comment that actually the sensitivity is not high as 90%. It is up to the midway, somewhere 50 to 60%. But the specificity on the counter is actually high. When it says it is malignant, then the chances of malignancy are quite high. But picking up the malignancy or picking up the actual histopathology on the basis of molecular testing is not as high as 90%. It may be in the tune of 50 to 60%.
But Ritesh, you have to classify whether you're talking about a rule-in test or a rule-out test. This
I think
specificity and
Ritesh,
sensitivity is different for
Ritesh,
both.
please, Ritesh, हम कोई debate नहीं कर रहे, and please just go out and check again about the sensitivity of Afirma, Thyrosequence, Thyronext. Everybody, every test has a sensitivity of more than 90%.
So
We are
this
not debating.
test is around
Thyrosequence is a rule-in test and Afirma is a rule-out test. So you have
Yes,
to see the sensitivity and sensitivity differently. Both groups are
differently.
different.
So the test which this medgenome test, this is around 27,000. So
Yes, yes,
it's
yes.
not even that expensive if you're working in a corporate sector when you are doing a number of tests in the corporate sectors which are required by the patients. We are not saying that you follow this in a government institute right now, but if the patient is demanding and they do definitely see Chat GPT and they come up with those things, so you have to be prepared.
We are doing it. We are doing it. Government sector, we are doing it.
See,
No
Yeah, I think the
problem for
we
government
us.
cannot
sectors,
say it's
they
not
should develop
affordable
their
in our,
own
we
kits.
cannot say
They
it's
can
not
develop their
affordable.
own tests, which are cheaper, almost free.
So we did robotic total thyroidectomy in this case, and histopathology, of course, came out to be benign. So there's one paragraph I forgot to put here in 8825 guidelines. If it is BRAF, if your molecular testing is BRAF positive in a category of OS, then definitely it is PTC. This is one line to be remembered. So the discussion is already done on these cases, a lot of molecular test discussion. So this is the slide which I was talking of. The identification of BRAF mutation or red fusion on molecular testing of thyroid nodule FNAC is diagnostic of PTC. So this is an important sentence which everyone should remember that. So coming to active surveillance in India and de-escalation of therapy. Now this patient, an 83-year-old lady from, of course, a doctor family, thyroid's 4.9 centimeter nodule. FNA came out to be PTC, Bethesda 5. Now, counseling for active surveillance and surgery. She was an ideal candidate. So, Dr. Himgarish, can you mention about the patients who are the ideal candidates whom we can at least ask for active surveillance? Dr. Himgarish? Is he there? Dr. Jabbar sir, you can take that question. Active surveillance.
Correct. I think I'm gonna say this is good case. This is a good case for discussion also. So microcarcinoma, especially the longevity of this patient, I presume that the patient age is 85 plus, and longevity is also probably is yeah, this is yours. Sure. Okay. So I think that this is a good case for active surveillance. Microcarcinoma, whatever the final diagnosis, the outcome, it's not that different. So I would recommend active surveillance if patients are good and very cooperative patient, you can go with them active surveillance. That's my view for this type of patient.
So what is your personal experience of active surveillance?
Yes, I also feel that for active surveillance for microcarcinoma, never experience is not a challenging one. If the patients are good, you can keep any patient under your camera. That's my view. We are doing it.
Yeah, so
Of course, we'll have a
thank you,
discussion
Dr.
with the
Jabbar,
patient
for
also.
sharing your experience, but unfortunately, I have not had an occasion to actively surveil the patient. Though we do offer active surveillance because we have the facility of a trained ultrasonologist and
Yes, sir.
cytologist. But
So we'll have a
I've yet to
discussion.
have a patient who has agreed for an active
Yeah.
surveillance. Yeah.
Yes, sir.
So the ideal candidates is like, who has an intrathyroidal microcarcinoma, more anteriorly located rather than posteriorly. And as Roman put up, clear, well-defined margins, no extrathyroidal extension, no nodal metastasis, and of course, a willing patient, a literate patient
Yes,
who
sir.
understands
Correct.
the implications of active surveillance. I think the key word in surveillance is the active part, where it's not that just patient is in your follow-up, but actively comes for a regular ultrasound done by the same ultrasonologist, So these things, I think, are important. Yeah.
Yes, sir.
Yeah, so however, she didn't agree for active surveillance and she underwent hemithyroidectomy with neuromonitoring and autofluorescence. And because we still do not have any patient on active surveillance right now, though we have been counseling few of the patients for the same. So what objective clinical triggers mandate? Next question is a shift from active surveillance to surgical intervention. When will you intervene in such patients? What factors? Dr. Ritesh?
Yeah. See, when we are actively surveilling a patient and the patient sonography are showing changes, nodule size is increasing. If the patient is already hypothyroid and the patient is taking thyroxine and still the nodule size is increasing, that is also an important thing. The nodule characteristics are changing on sonography, like development of microcalcifications or hypoechogenicity, changing from of thyroid score and worsening of the thyroid score, then definitely the patient should consider surgery. But before that, again, I would like to say that in such patients, NFNAC is a good tool to rule out what kind of a nodule we are dealing with.
So FNAC was PTC.
In FNAC, yeah, sorry. If FNAC was PTC, if the nodule size is increasing and it is this thing invading the aerodigestive tract or development of a nodular lymph node metastasis, then it mandates surgery.
So basically increase in the size of the nodule in size like 3 mm or
And
50
invasion,
maybe nodes, if
invasion,
suspicious nodes develop.
Yes.
invasion and
Appearance
nodes.
of new nodes. So these are the factors which you have to intervene at that time.
Yeah.
However, there are certain practical limitations in India, and I'm sure everybody is dealing with those. So, Dr. Naval, would you like to share your experience? Do you have any patients of active surveillance or there's some
No,
patients?
usually I believe if I am dealing with the 83-year-old female who is thyroid 5, if I feel the patient is fit enough to undergo some sort of procedure, then I evaluate with FNSE or other modalities. And if FNSE turns out to be papillary CA thyroid, I usually prefer going for a surgery rather than putting the patient on active surveillance, because that is a practical scenario. If I feel at the age of 83 she is not fit today, how come she become fitter maybe 2 years down the line? So if the family is not willing to undergo some sort of procedure at the age of 83, the family will not be able to, I will not be able to convince the family at the age of 85. So that decision has to be made at the same time whether the family wants to do something or not. It's not the patient herself or himself at the age of 83, it's the family who's taking the decision. So that first contact is very, very important. I personally don't want to do active surveillance, because once you say we can do a surveillance, the entire responsibility falls on you rather than on the patient. This is an unfortunate scenario in the India.
Yes.
So I usually tell that lady can undergo surgery because we have enough infrastructure, especially where we are working, where we can handle these sort of patient. If the patient is totally unable to undergo surgery, then doing a active surveillance actually will not help much. Because if it is she is not fit enough today, like I mentioned earlier also. So this is my take. If the patient is diagnosed to have a papillary CA, I'll definitely go for a surgery.
Dr. Rajput, Dr. Rajput sir, do you have any difference in opinion?
Actually, honestly speaking, in my life, I have never gone for an active surveillance. I have a good I have a good endocrine surgeons as my friend, and I believe in their capabilities. So age is not a contraindication for me for surgery. So until and unless patient attendant refuses that they does not want an 80-year-old lady to undergo a surgery, and then only I say, okay, we will keep and watch. Otherwise, personally, I always ask them, this, although we are discussing a thyroid nodule, recently I have an 84-year-old lady with parathyroid nodule, hyperparathyroidism, and they are actually close from Lucknow. And we have said that it can be removed very safely, severe osteoporosis. But the family is not agreeing that 83 year of age, we does not want to undergo surgery. Okay, fine. That type of active surveillance, I agree. But if a patient attendants are not able to take the responsibility, are not willing to continue the active surveillance, then probably it is best to offer a surgery, because in experienced hand to me, removing a small thyroid nodule or doing an hemithyroidectomy is not a big procedure for my experienced surgeons colleague.
So
I
basically,
believe.
we are the ones, the doctors are the ones who are hesitating right now for active
Yes.
surveillance. And this is
Yes.
the in India, that is the major bottleneck, I suppose.
Yes, absolutely. Agreed. Bilkul.
And the patient that you're talking about, hyperpara, I think he consulted our endocrinologist as well, and our endocrinologist as well were trying to convince that patient for surgery.
Acha. So,
Yes.
they have met you.
No,
So,
not me, my endocrinologist, not me, not me,
okay.
not us.
Okay.
So finally, I think for the active surveillance, we are still lagging, and but that's of course an option. Coming to the surgical, this is the last part of hemithyroidectomy and total thyroidectomy. I would like Dr. Amit sir to take this question. So, what is your approach to low risk malignancy less than 4 centimeters? How will the clinician decide between lobectomy or total thyroidectomy?
It's a very tricky question in the era of guidelines. As ATA guideline would say, less than 4 centimeters, you may do a lobectomy. So, you know, my decision making is I keep the patient in the center of our discussion. I look at the opposite lobe. If the opposite lobe is normal, then if there are small nodules, then I would not give a choice for a hemithyroidectomy. If the patient has extrathyroidal spread, obviously I would not. So a close look at the cytology, the ultrasonography would really make a decision. But when you say less than 4 centimeters, it means more than 1 centimeter and less than 4 centimeters.
Yes.
Yeah. So my take till now was a total thyroidectomy, but I think I have a bit changed my practice. because of my change of place. And I would still offer a thyroid lobectomy as a legitimate choice to the patient.
Yeah, very well said, sir. So I think because of paucity of time, I'll move ahead. And for the radioactive iodine part, our panelist is not there. So I would like to conclude the session now. So with that, I would like to say that modern thyroid nodule management focuses on separating clinically insignificant findings from aggressive malignancies by leveraging TIRADS for risk stratification and molecular testing for indeterminate FNAs. So key takeaways includes a shift that we have seen utilizing hemithyroidectomy now over total thyroidectomy to reduce surgical complications while ensuring oncological safety and active surveillance. Of course, we have to really work hard, and maybe the clinicians first, as surgeons and endocrinologists, we have to first think that whether we can actually give this option to our patients or not. So thank you all, esteemed panelists, for this wonderful discussion. Anybody would like to add to this?
Thank you.
Thank you, Roma, and Rajesh, Dr. Jabbar, Ritesh, and all. Thank you.
Thank you. Bye. Good night.
Thank you.
Thank you.
Thank you so much, Dr. Roma.
Thank you, Roma, so much.
So now I hand over to Dr. Ganavi, please.
Yes, ma'am. Thank you, ma'am, for moderating this session so wonderfully. And thank you all the experts for this very highly practical and insightful discussion. So we now move on to an exciting segment of today's webinar, that is the interactive thyroid quiz session. The session will be moderated by Dr. Mohan T. Shenoy, sir, who is the Senior Consultant Endocrinologist at Sri Gokulam Healthcare Institutions. And I request sir to introduce the quiz master for today's session, Dr. Kushbu. Over to Dr. Mohan.
Thank you. Thank you. I hope you are listening to me. Audio is clear?
Yes, sir.
Thank you. Thank you, dear team. Thank you, Pramila madam, and all the seniors who are here. Thank you for giving this opportunity to me. So welcome, Dr. Kushbu. So she is the young, bright star of thyroidology and endocrinology. She is working at Kanpur. She has got so many laurels at a very young age. So over to you. So today you will have a quiz on all the topics of thyroid, or only this webinar?
On all the topics, sir.
Very good. Very good. So it's a
TRP
comprehensive
journal, also from Thyroid Research and Practice
TRP.
Journal.
So I request all of you to also join ITS who are in the cloud. Who are not joined, please join the ITS. We have got a flagship journal called Thyroid Research in Practice, in which we publish all original articles and research. It is started by our own teachers. So over to you, Dr. Kushbu. Can you share your screen and let us see how the quiz goes ahead?
So before Dr. Kushbu starts the quiz, I'll just display the quiz rules. Yeah.
Yes,
So
yes.
to participate in the quiz, it is important to click on the button Attend Quiz given on the screen, which is being live streamed. The quiz will be conducted through a platform called the Slido. So you are requested to use a laptop for the ease of experience. The quiz will run for 5 minutes. The quiz master will display a case or a description of the question by screen sharing a PowerPoint file. There'll be 10 questions, and each question will be available only for about 30 seconds with the timer being on. And yeah, so it is important to avoid refreshing the page during the quiz. And I hand over the session to Dr. Kushbu again. So we wish all the participants the very best. So over to Dr. Kushbu.
Yeah, very good. All the best.
Thank you. At the outset, I would like to thank the team of Indian Thyroid Society for giving me this opportunity. And while preparing, it was a learning opportunity for me as well. And it was a good way to actually revise a lot of concepts. So all the best to all the participants. Without any further delay, I'll be sharing the questions. Okay. Is my
Wait, ma'am. No one is joined till now.
okay?
I think we need to display the QR code, right?
Yes.
Where is the QR code?
IT team, please, can you display the QR code? We need to give 3-4 minutes time for the people
Yeah.
to
We need to
join.
give some time.
Yeah.
Correct.
Kushbu ma'am, can you stop your screen share now, ma'am?
Yeah.
Can we also participate?
No.
No.
Not at all. Absolutely not allowed.
Why do you want to embarrass yourself, Mohan? Keep quiet, please.
Then how will others get the chance, Mohan?
No, nobody has joined. He is telling, so at least we'll start to learn something. Bashiruddin ji, are you on it?
So there are only 3 members are joined because we kept the link in the platform only.
Okay.
There are 3 members already joined, but
Okay, then.
voting for others.
Madam, you are muted, ma'am. Madam, yeah.
Students are joining. Just 4 minutes you give.
Yeah, yeah.
Students are joining. 3
Yes, yes. National groups we can post otherwise. Yeah. That QR you can display here also, no? Yes, I think QR has come. Thank you. So those who are listening to this program, except the office bearers and the panelists, please try to scan the QR code. It will be on the screen for some time. It's live. Hope we get more people joining.
They're joining.
Yes, yes.
Yeah, because the little typing time thing has happened because
We need double-digit values.
yeah, so that's why they'll just join. Just 2-3 minutes we'll have.
Yeah, yeah. We'll just keep it like this. Once we are ready, please let us know, Bashirji. Good number should be there.
Okay.
Sir, we can start, sir. There are
Yes.
12
The
12
dummy
members
question
are
is there. Dummy question
Yeah.
is there.
12 members are there. We can start, sir.
Dummy question is there. No, no.
Huh?
No, sir. No dummy
No,
questions.
no
sir.
dummy question. No dummy.
Okay, okay. So all the best. Over to you, Dr. Kushbu.
Okay, I'll be sharing my slides now.
Yes. We can see your screen. Make it
Thank
full
you.
screen.
Yeah, make it slideshow.
Yeah, yeah.
So
Okay,
I'm
so
starting now.
timer is there internally, or we are going to just display the questions now?
No, they will give a hint when to move ahead. So the prompt will
Yes,
come.
sir. Yes, sir.
Yeah, they'll
You can
give
start,
prompt.
ma'am. Kushma ma'am, you can start.
Okay.
Thank you. So, participants, the first question is a very important public health question. So, urine iodine levels that indicate iodine sufficient population, which of this is true? More than 50 microgram per liter, more than 100 microgram per liter, more than 150 microgram per liter, or more than 200 microgram per liter?
Ma'am, next.
Okay, moving on to the question number 2. A known complication of a very important life-saving drug. So, amiodarone-induced thyroiditis. What is true? All except. So, there are 2 types of amiodarone-induced thyroiditis, type 1 and type 2. So this is related to type 1. So antibodies such as TPO antibodies, TSI, thyroglobulin are high, or it occurs in iodine deficient area. It occurs 3 months after starting treatment, and scintigraphy shows decreased uptake. One of the following statements is wrong. Please let us know which one is it.
Next one.
So, a very important physiological question: which of the following medications or hormones stimulates the release of TSH? We have arginine vasopressin, dopamine agonist, glucocorticoids, and cholecystokinin. One of them stimulates, all the other are inhibitors. Which one is it?
Next one.
Moving on. So, everything goes through the receptors. So the question is, which is the correct description of thyroid hormone receptor? Is it an intracytoplasmic receptor? Is it a nuclear receptor? Is it a G protein coupled receptor, or is it a steroid type receptor?
Next one.
So we are halfway through. So an important discussion, because both of them are very common diseases, diabetes and subclinical hypothyroidism. All of them you should treat, except when the age is more than 65, when there is a goiter and you have retinopathy, then antibodies are positive.
Next one.
So the next question is, all of the following are true for osteoporosis, that is in subclinical hyperthyroidism. It relates to the duration of disease. There's a risk of fracture that may persist for up to 5 years. It is higher in men more than 70 years and postmenopausal women. There is a reduction in lumbar spine bone mineral density. Only one of them is true. One of them is false.
Next one.
So, subclinical hypothyroidism, while everybody throws this term around, is not, it does have a lot of confounders that have to be ruled out. So, this slide mentions some of them. Which one is not it? So, impaired renal function, impaired liver function, age, thyroiditis. One of them cannot be confused for subclinical hypothyroidism.
Ma'am, next.
So we had a nice discussion about this as well. However, once you have done a thyroidectomy, what to do next? So the next step is to measure thyroglobulin levels, and the question is, how soon can you measure, and what is, so is it immediately after the operation, after 1 week, 6 weeks, or 6 months?
Next man. Next man.
So the second last question, I think everybody should answer correctly. Which is the most common muscle involved in patients with Graves' ophthalmopathy? Inferior rectus, inferior oblique, lateral rectus, superior oblique.
Next man.
So the last question, we have a lady with a 1.5 centimeter firm painless thyroid nodule, which was noticed 3 months ago because of the size. The FNSE was done, which showed Bethesda class 2. What is it? Is it a follicular adenoma? Is it non-diagnostic? Is it non-neoplastic? Or is it suspicious of malignancy?
Done, ma'am.
Well,
Okay.
very good.
Thank you.
Thank you. Thank you. So I think we are going to wait for some time, or we have the results already.
Yeah, so let the technical team decide the results. So meanwhile, let's share the result. Let's
Okay,
discuss
you
the
want the
answers.
discussion first. Okay, Bashir, just close the screen. We'll allow Dr. Khushbu to just finish the answers discussion. Yeah. Yeah, go ahead, Dr. Khushbu. Let us learn the answers.
I'm pretty sure, sir, you already know.
No, no, it's all good.
But anyways, so these are the
Okay, full screen.
Yeah. So the first question is, this was a little tricky question because the levels differ according to what population you're testing. So it depends on, it is a little different for children, it is a little different for pregnant patients, and it is and lactating patients. But overall, one answer that stands out for most patients is more than 100 microgram per liter is indicative of adequate iodine nutrition in all patients, except patients who are pregnant who require more than 150. So that's why the answer over here is 100 microgram per deciliter. So the second question is amiodarone-induced thyroiditis. So typically with thyroiditis, we see decreased uptake. So this is one thyroiditis which actually has increased uptake, and this has to be kept in mind. It is common in iodine deficient areas, occurs approximately 3 months after starting amiodarone, and the uptake is very high. Antibodies are positive, but IL-6 is normal. And in this type of amiodarone-induced thyroiditis, antithyroid medications need to be given for approximately 6 to 18 months. And then it depends on the duration of amiodarone as well. So again, AVP is a stimulator of TSH. All the others are inhibitors. So this was from Williams Endocrinology. You can see that AVP is a stimulator. All of the others come from inhibitory agents, cholecystokinin, dopamine agonists, as well as glucocorticoids. So this was a little confusing question because all of us assume thyroid receptors to be nuclear receptors, but this was a TSH receptor, and TSH receptor is a G protein coupled receptor. So something you have to keep in mind. So the next question was subclinical hypothyroidism and diabetes. It's always a question which patients to treat, which not to treat. So this was a very nice review article in Thyroid Research and Practice. It actually gives a very nice flow chart. So patients with nephropathy, retinopathy, high cardiovascular risk, presence of goiter or antibodies, you have to treat. But all of them are less than 65 years of age. More than 65, as long as your TSH is less than 10, you keep them on follow-up. So again, osteoporosis with subclinical hyperthyroidism, this actually is an indication for treatment, and I think the answer would have been very clear. So there's an increased risk of hyperthyroidism and an increased risk of fracture according to the duration of disease. and it is more in postmenopausal women and people who have suppressed TSH even after months of treatment. So there's a reduction in femoral neck BMD, but not in the lumbar side BMD. So this was slight difference that was there. So again, subclinical hypothyroidism, which is a confounder. So again, this is a very nice review article of subclinical hypothyroidism. And this is a nice table of differential diagnosis with age, with obesity, with impaired renal function, untreated adrenal insufficiency. All of them can result in false high TSH values. However, it is not seen in impaired liver function, something to keep in mind. So the eighth question, so this was a little tricky question because typically all of us do thyroglobulin at 3 months time. However, the question was how soon after thyroidectomy can you do it? So this is a paper that was published. Then they make a case of early post-operative unstimulated thyroglobulin, which can actually indicate whether the patient is going to go into remission or require radioactive ID. So they put out a cutoff of 0.2 nanogram per milliliters at 6 weeks of surgery as a cutoff. If the patient has thyroglobulin less than this, then they probably don't require radioactive iodine. So again, this is, I think, most common muscle, and I think all of us already know it. So this is the article from Rebecca Barn, I think one person who is associated with Graves' ophthalmopathy, and she has a very nice review published in NEJM. So this is from that paper. So again, a very important question, a very confusing topic. A lot of debate happens in a lot of sizes, how when to keep on follow-up, when to operate, when to do an FNSE. So the best thing is to go about do an Bethesda screening with an FNSE, depending on the size. So again, consensus statement for the management of thyroid nodules from our Indian Thyroid Society. So you can see that Bethesda class 2 is benign, and you can keep them on follow-up to see whether the size increases or not. I think that's all. Thank you.
Okay, great. So let us see who have won the quiz.
Sure, sir. Screen the sheet.
Yeah. Fingers crossed. I hope none of us are there.
You cannot be there. If you're there, also will be deleted anyways.
So who is SP?
I think I don't know. We'll have to find out.
Yeah, we have to find out. So congratulations. SP is the one winner. Number 2 is Kavya, Dr. Kavya. We don't know where are you are from, but still it's good to have a great. And third one, I know he's from AJ Institute of Medical Science, Mangalore. Dr. Ganesh's student, Dr. Satyamsi. So I think I know one person.
I think Kavya is our student, but I'm not sure. She hasn't written the full name, so I'm not sure. SP may be our student also, possible,
Please get in
Soumya, but
touch
I'm
with
not
the
sure.
ITS secretariat and on
Yeah.
the email, on the website. Please get in touch with any one of us, so that we'll help you out. And of course, Arun sir is here. So the prize money and all, he will be telling us.
Mohan, we are poor people.
We are good in knowledge. We share knowledge.
We give knowledge and wisdom.
Yes. That is more important.
That is more important than money.
So thank you for having me, and thank you, Kushbu. And over to you, Dr. Ganvi. And madam.
Yes, sir. Thank you, sir. So definitely it was a wonderful quiz discussion, and we would if the attendance was good, it would have been much more nice. So we can congratulate all the top 3 winners, and thanks all the participants for making this session truly engaging. So it's definitely a wonderful display of knowledge and enthusiasm as well from Dr. Kushbu and the quiz winners as well. So as we come to the conclusion of this Enriching World Thyroid Day webinar, I request Dr. Arun sir to give the concluding remarks. Over to Dr. Arun sir for the concluding remarks.
Thank you, Ganvi. Thank you once again. It's my pleasure and privilege to thank all the speakers from tonight. It's a long list, so I'm not going to going to name all our ITS members, but I think it is very important that we thank first our founder president, because I think that is something which we have to do. R. Vijaykumar sir, who has been the pillar, who has been, so he's equal to Indian Thyroid Society. So I think we thank him for sparing the time and addressing us. All our Star Wars, without naming names, they've been in the panel. Thank you all once again, all the ITS, Star Wars. I would like to especially thank Dr. Amitabh Arya for a very nice lecture on the radioiodine in the management of thyroid disorders. On the panel, the second panel discussion, a special thanks to Dr. Amit Agarwal. Himgirish was not there, I think, so he didn't join. Ritesh, thank you so much. Naval Bansal and Dr. Vineet Mishra. So it was really very lively discussions, especially Vijay and Roma did a great job with both panel discussions. And the quiz, I think, as Ganvi was saying, it's a real shame that we didn't have more people. I think it was a very, very well constructed quiz questions. Thank you so much, Dr. Khushbu Agarwal, for doing a great job. I don't know whether I've left out anybody. If I have, please apologize. I would like to apologize for that. But thank you all once again. I hope we will continue this good work, and Pramila and her team of CN and Ganvi, of course, have a special mention of what you have been so consistent over the last 4 or 5 years, and you have really held this together. So thank you so much once again. I hope we can we'll meet as usual in the next month for our online CME, which I'm sure will have more attendance as well. Obviously, this time it's been a little bit out of sync, largely because of the World Thyroid Day. So the next one is actually on 10th of June. So it's coming very quickly. So it's going to happen in 2 weeks' time. So thank you all once again, and good night.
Thank you, sir.
Thank you. Good night. Bye-bye.
Thank you, sir. Good night.
Good night.